Thank you, Jean-Louis. Thank you for your kind invitation, and good afternoon, everybody. So, advantages of echocardiography Doppler device. It's non-invasive, minimally invasive device. It allows a functional hemodynamic monitoring. It means a new approach for hemodynamic monitoring, and I will illustrate this point very shortly. Dissociated from cardiac output and pressures measurement. And it gives an immediate impact on treatment and management for your patient at the bedside. Non-invasive or minimally invasive device. Look at the scale of invasiveness regarding most of the tools that you can use at the bedside for hemodynamic monitoring. And you can see that when we speak about echocardiography, we have two main routes, the transthoracic echo, and indeed the transthoracic echo is totally non-invasive, and the transesophageal echo, which is not non-invasive but minimally invasive. And look at this very large series of examination published in Acta Anesthesiologica Scandinavia in 2004, more than 2,000 examination, TEE examination, and you can see that the complication, the rate of complication was 3.5%, and only 2.5% if dislodgement of feeding tubes was excluded. And you have to know that most of complication occurred in spontaneously breathing patients. Of course, when you have to use this kind of tool for hemodynamic monitoring in critically ill patients, most of patients or all patients are sedated under mechanical ventilation. Second advantages, and the main advantages, is that it allows to do a real functional hemodynamic monitoring. A new approach for hemodynamic monitoring dissociated from cardiac output and pressure measurement. And maybe it allows to stop the cult of the magic numbers. I will illustrate this point very shortly. Two very short histories. Look at this man hospitalized in ICU for shock, septic shock related to pneumonia. And you can see that he had persistent shock despite fluid infusion. And so at that time, after initial resuscitation, you have to know what to do for the patient. And look at, for instance, you can use transthoracic echo. And you can see here the inferior vena cava. The inferior vena cava was very small. With large respiratory variations, you can see the dilatation of the inferior vena cava during each insufflation. At that time, you know that you have to give fluids to improve the patient's status. And we gave fluid to these patients. Look at the cardiac index, of course, significantly increased. And look at now the inferior vena cava. You can decide to stop to give fluids, or if you did not reach the endpoints, the resuscitation endpoints, you know that once again this patient will respond to fluids, because look at once again the inferior vena cava, look at the dilatation of the vessel during each insufflation, reflecting fluid responsiveness. And in fact, in this patient, we gave a second step of fluids, permitting to increase much more the cardiac index. And look at now the inferior vena cava, we decide to stop to give fluids to this patient. So a very simple approach. Another example, of course, using transesophageal echo, just to illustrate the concept. Look at the superior vena cava. You can see here the superior vena cava, and you have the superior vena cava here. When you observe this kind of collapse of the vessel during each insufflation, you know that the patient is hypovolemic and that you have to give fluids to improve the patient. And look at after fluid infusions, we improved a lot the patient status, and we induce a decrease in the respiratory variation of the superior vena cava. Once again, it's a very simple approach. And finally, to well illustrate this concept of functional hemodynamic monitoring, I want to take a few minutes to explain how to do the diagnosis of cardiogenic shock using, for instance, a pulmonary artery catheter. You know that you have to observe this relation between the LV filling pressure and between a parameter of systolic function of the left ventricle. And as you can see, when the filling pressure is high and the systolic, the parameter of the systolic function, is decreased, you can do the diagnosis of cardiogenic shock. Look at here this relationship in 5 septic shock patients. And if I ask to the audience and to the experts, how are these patients, I think that most of people here will say that these patients require fluid infusion. And in fact, we did fluid infusion. We did infusion of fluids in this patient. And look at the first step and look at the second step. And you can observe that by giving fluids, we unmasked left ventricular systolic dysfunction. Look at the relationship between the pressure, the filling pressure, and the systolic function of the left ventricle. And after infusion of the butamine, we restore at that time the performance of the left ventricle. So probably it's much better to directly observe kinetics of the heart to do the diagnosis at the bedside of systolic dysfunction of the left ventricle, for instance. And look at this patient after a few hours resuscitation for septic shock in our unit. Look at the left ventricle. The left ventricle was severely hypocontractile. And look at the same patients now, 6 days later after recovery. Look at now the contractility of the left ventricle. So it's much more easier to do the diagnosis of left ventricular systolic dysfunction, for instance. The third advantages regard, of course, the immediate impact on treatment and management. You do the echo at the bedside, you have the results, and you can immediately change the treatment. And look at once again this large series, 2,500 examination in ICU. And you can see it's very interesting to see that TEE was performed in half of patients for hemodynamic reasons, hemodynamic instabilities, or to assess ventricular function. And what were the results in this large series? The results was left ventricular dysfunction in 30% of patients, right ventricular dysfunction in 10% of patients, hypovolemia in 10% of patients. It means that in half of the examinations, the intensivist had immediate information regarding hemodynamic status of patients. And so the diagnostic impact was very high, the therapeutic impact was also very high, and finally the surgical impact was significant. So are there limitations? I am not sure, Daniel, but I have to write some limitation and to discuss some limitations. Discontinuous monitoring, right. No randomized control trials regarding prognosis and mortality associated to the use of this technique. Operator dependent, and a problem of training and teaching of most intensivists around the world. Discontinuous monitoring, that's right, I agree. But you know that you have some goals of hemodynamic monitoring. You want to reach some endpoints. And of course, you have to associate echocardiography with continuous monitoring device. Jean-Louis spoke a lot about blood pressure. Of course, you have to associate invasive arterial pressure with the use of echocardiography. And you know that, look at this very nice study, the time under 60 millimeters of mercury of the mean arterial pressure was significantly associated with a poor prognosis. But you can also measure the base excess or measure the lactate level, Jean-Louis, of course, and you can associate this measurement, this continuous monitoring with the use of echo if you think that something is wrong. And this was finally nicely recommended by Massimo and the expert of this consensus conference in Paris. Because what they said that they recommend invasive blood pressure measurement in refractory shock or in severe shock. I totally agree, of course. They recommend to have a marker of inadequate perfusion, maybe SCVO2 or maybe lactate level or maybe base deficit. And you have to associate these different parameters with the use of echocardiography in patients who remain in shock after the first fluid resuscitation. Look at this very simple example in a septic shock patient. Day 1, base deficit 19 millimoles per liter, systolic arterial pressure very low. Echocardiography. By a transesophageal route, look at the right ventricle, dilated, look at the interventricular septal motion, paradoxical septal motion. So this patient demonstrated acute curve pulmonary regarding to the septic process. He was under mechanical ventilation. Day 2, norepinephrine, 6 milligrams per hour. The base deficit was corrected. The systolic arterial pressure was good. And in fact, the cardiac function was good. Look at the size of the right ventricle and look at now the shape of the left ventricle. 1 day later, day 3, norepinephrine 6, base deficit now 6 millimoles per liter, systolic arterial pressure 80. So something is not good. Once again in this patient, echocardiography. Look at now the left ventricle, the contractility of the left ventricle. Using the short axis view of the left ventricle, you have the diastole, you have the systole, and this patient now had a severely depressed contractility of the left ventricle. So dobutamine, 5 micrograms per kilogram per minute, permitting to decrease norepinephrine dose and to restore a normal blood pressure and to correct the metabolic acidosis. And look at now the examination of this patient, look at the right ventricle, and look at the contractility of the left ventricle. So it's a good example how to combine echo and parameters of perfusion or systolic arterial pressure. No randomized control study, that's true. Maybe it's a limitation. You can read this good paper published by Jean-Louis in Intensive Care Medicine, and you have here on this figure most of the hemodynamic tools which were reported to be associated with improved prognosis in critically ill patients. And no echo, that's right, in this kind of studies. Operator dependent, of course, operator dependent and variability of measurements. This is why probably a qualitative or semi-quantitative approach is much better than to do measurements and to do some errors according to the operator. And look at this study that we published in Intensive Care Medicine, and we asked to our intensivist to evaluate qualitatively the contractility of the left ventricle into 3 groups: normal contractility, moderately depressed contractility, and severely depressed contractility of the left ventricle. And if you do that, it's relevant in terms of treatment. Look at in case of normal contractility group, the left ventricular fractional area contraction was close to be normal in most patients. And look at in severely depressed contractility, the left ventricular fractional area contraction was lower than 40%, so it was severely depressed in fact. The results are much more balanced in the intermediate group, in whom sometimes we don't know if we have to infuse dobutamine or not to infuse dobutamine. Training and teaching, of course, it's a huge challenge. We start with some American societies to develop some guidelines and to discuss about competencies that intensivists have to use this kind of technique at the bedside. And you know that in this paper we define what is a critical care echocardiography performed by the intensivist at the bedside. And you know that, but I will discuss this point tomorrow in more details, but we separated critical care echo into very different levels. Basic echo, basic critical care echo, which is an early goal-directed echo. Very simple parameters to well-resuscitated patients at 2 hours in the morning, for instance. And an advanced level, which is really an hemodynamic tool, an hemodynamic monitoring tool, and that requires much more competencies in ultrasonography. Just to, and I want to conclude with these 2 slides, to explain you that without any experience, any previous experience in echocardiography, it's possible in 6 months and some examinations to have some competencies to use transesophageal echo to have a good hemodynamic monitoring assessment. And we built a scoring system to assess the skills of our intensivist. And just to see you that the maximum score was 42. It doesn't matter how we build the scoring system, but you can see that after 6 months and close to 30 examinations per intensivist, most of the intensivists was able to have the maximal and close to the maximal score, suggesting that they were totally able to do a complete hemodynamic evaluation of the patient at the bedside. So to conclude, it's a minimally non-invasive device. It allows a true hemodynamic, more functional, without numbers. It has, of course, to be associated with a device allowing continuous monitoring to assess the adequacy of perfusion. It's so important. It has an immediate impact on treatment. On prognostic, we don't know. And it requires, of course, competencies regarding training, and so training and teaching has to be organized. Thank you for your attention.